Welcome to the Future of Dermatology Podcast. I'm your host, Dr. Farah Kamangar, board-certified dermatologist. Along with being a dermatologist and the host of this podcast, I am also the president of the San Francisco Dermatological Society, which is composed of dermatologists who practice in the San Francisco Bay Area. Every year, we hold our annual SF Derm meeting, and this year we gathered our guests at the Ritz-Carlton in Half Moon Bay. From engaging sessions to incredible food and even a round of golf, SF Derm 2024 was a huge success. Continue listening to hear thought-provoking conversations from our incredible dermatologists who presented on matters that answer your dermatology questions, align with our goals, and provide insight to the future of dermatology.
These are truncated replays from our original recorded sessions. Join us next year to get the full impact of the SF Derm experience.
I have the great pleasure of introducing Dr. Daniel Klufas, who is our next speaker and my dear colleague who I work hand in hand with to take care of patients with HS at UCSF. Dr. Klufas is both a board-certified dermatologist and fellowship-trained dermatologic surgeon. He's an assistant professor of dermatology at UCSF, medical director of derm surgery, and director of quality improvement at ZSFG, or Zuckerberg San Francisco General Hospital. His practice includes office-based procedures for HS, laser procedures, and of course he has the most practice. And I'm excited to have him come up here and talk with us about deroofing for hydradenitis suppurativa. So please give him a hand.
So HS was long considered a purely surgical disease and sometimes required these large, morbid procedures. But with recent strides in medical management of HS, that architectural damage can be deferred for a longer period of time and sometimes completely delayed. So this has really created a shift in how we need to manage HS surgically. In general, patients with early stage 2 and 3 disease still remain really great candidates for surgical management. But I really think that any stage of disease can benefit from some procedural intervention. You may read in the literature, you may have seen there are a lot of different procedures you can do for HS patients. I'm going to be focusing solely on deroofing today. I think it's absolutely critical that before anyone is considered for a surgical procedure that they come have a consult. So I know it's a little bit of a burden for some of the patients, but I really like to meet them. And I think the reason for that is you can start to set the stage for what does my patient actually want? What can I do to actually get them to that point? And then what kind of procedure can I actually do? So first and foremost, as Dr. Nayak mentioned, we want our patients medically optimized. I'm going to come back to that in a few slides, so I'm going to just table that for a second. Next, I perform a complete physical exam, and this really allows me to see which sites are most affected and which I think are going to benefit most from surgery. And then I actually spend a lot of time talking about the pathophysiology of HS. I really stress that it's a multifactorial condition, there's no cure, and that once this architectural damage is created, there's really no medical therapy that's going to reverse that. So then my role as a surgeon is that I can remove that tissue and then hopefully prevent that, or really remove that nidus for recurrent inflammation. HS takes a huge financial, social, emotional toll on our patients. So I think it's really important to consider all these social determinants of health, because if you can't optimize that before surgery, it's unlikely to be successful. And then finally, do a pre-surgical checklist just to make sure you're going to reduce your risk of any complications. So let's talk about medical optimization. And I have to give credit to Dr. Fee Jawali, who's one of our actually just recently graduated UCSF Derm residents. He's now going to be our surgical fellow. He actually came up with this definition with Dr. Nayak in his senior expert talk. And basically he says, medical optimized means preventing the development of new lesions in new locations. And I think that's a pretty succinct and eloquent way to think about it. Once this has been achieved and your patients are still getting sort of that recurrent sort of localized lesion, that's when I think they're a great candidate for deroofing. Deroofing candidates, though, in summary, so this is largely early stage 2 and 3 disease, presence of clearly defined surgical targets, recurrence of localized lesions, and then obviously, like we said, on some current medical management. I think the patients who are not necessarily great candidates for deroofing are the ones with really extensive early stage 3 disease, where it's involving some critical structures, either of the genitalia or the perianal region. And these are the ones that I usually refer or get help from with my surgical subspecialists, whether it's plastics or gen surg. So let's jump into the actual deroofing technique and some surgical pearls. So by definition, deroofing is the removal of all or a large majority of the skin overlying an HS cavity with the base left intact following debridement of the base. The optimal surgical site in the moment is one that's not actively inflamed. If we have time later, I'll talk to you about things you can do to manage it if they are actively inflamed. The great thing is this can be performed for solitary lesions, but it can also be performed sort of in a regional manner or in a staged manner. And then finally, it carries pretty low morbidity and really high patient satisfaction. Now, most of these tools that you need for deroofing, at least the way that I perform it, you already have in your office. The first thing you might not have is this double-ended surgical probe. It's a blunt, straight, malleable probe. It's usually about 6 to 7 inches in length, and it really just helps you identify the extent of the tracking tunnel. You'll need some good tooth forceps, some sharp scissors. I prefer supercut scissors because you're going to encounter a lot of scar tissue, a scalpel, either a 10 or a 15 blade. And then I use mostly sterile gauze for my debridement, but sometimes it's very adherent to the base, so I think a curette is often good to have handy. So in one study of about 88 patients, they showed that with an average defect size of about 3 centimeters, it only took about 2 weeks to fully heal. And I think this is actually true for most of my patients, although I do counsel that it could take anywhere from 2 to 8 weeks to fully heal, and that's largely dependent on how deep the wound is. Like I said, we typically recommend pretty simple wound care for our patients. They're going to apply a thick layer of petrolatum at the base. When they're showering or bathing, they're going to perform some gentle debridement, and then they're going to use bandages that are specifically designed for the sensitive skin around where we've performed the deroofing. Here are examples of dressings that I do like. So on the right there is the Allion Med silicone foam and with a gentle adhesive border, and then the Alevin gentle border light. The nice thing about these is they do stick well in intertriginous areas. They're absorbent, and they're very gentle on the wound edge. Going back to second intention healing, yes, it takes some time, but it really prevents reformation of those tunnels if you were to, potentially try to suture this together. It does, when it is fully healed, that scar is going to contract by about 25 to 60%. So I'm always impressed at how big some of these wounds are and then what it looks like a bit of time later. There's no donor sites from a flap or a graft, no risk of necrosis, and usually allows an acceptable range of motion. One thing all my patients always ask me is they say, how much pain am I going to be in after this? And I think a lot of them have already had surgery from someone else who's done some big morbid procedure. And I tell them that actually it's better than they think. And there's papers that are published on this. So in this study of 126 patients, 65% of patients said the pain they had from an HS flare was worse than they had from post-procedure pain. Nonetheless, I provide some anticipatory guidance. I like this over-the-counter regimen of acetaminophen altered with some ibuprofen and ice. But if it's a more sensitive area or someone with a lower pain threshold, then I will recommend acetaminophen with some hydrocodone. And then I think with any procedure, it doesn't matter exactly what I do. It matters how happy people are with it. So how happy are people with excisions and deroofings and things like that? So in the top study, this was in JAMA in 2022, they looked at 194 deroofing and excision procedures, and 84% of participants said they would recommend it to a friend. 86 said they were pleased with the procedure, and 81 said they felt that the procedure met their expectations. The bottom study was actually of 79 patients who just had deroofing, and they did a numerical score of 0 to 10 and how satisfied they were. Achieved a score of 8, which I think is pretty good. And then 90% of those patients would recommend it to a friend. Slightly lower recommendation if they had a recurrence, which I think is reasonable. And that leads me to my next point. So I'm always asked, is this going to work? And I think really what patients are asking about is, are they going to get a recurrence in this area? Now, the data is pretty heterogeneous out there, but if you look at it, it usually ranges from about 0 to 31%. Saylor et al., one of our colleagues at UCSF, when they did a pooled analysis, they showed that the recurrence rate was actually 14.5%, but those patients were not in any adjuvant medical therapy. It was actually 0% on all the patients who were actually getting medical therapy while they had their deroofing. And if a recurrence does occur, it's generally smaller and easier to manage. And then a lack of recurrence doesn't mean that you should stop the medical therapy. Finally, what's the complication rate? Again, it's a pretty broad range out there. I think the things that I encounter most are bleeding and hypergranulation. Infection is exceedingly rare. I think I've only had one infection in the last year. For hypergranulation, what I like to do is I tell them just to dial it back a little bit with the occlusion of the dressing and then the petrolatum just to reduce that tissue hypoxia. However, you can also use some clobetasol ointment that can have this vasoconstrictive effect and then also reduce some of the inflammation. So in summary, preoperative planning and appropriate patient selection for HS can really lead to optimal surgical results. Deroofing is an office-based procedure that can augment the course of HS with some excellent outcomes. And deroofing offers low recurrence rates, low morbidity, and high patient satisfaction.
Thank you for listening to the Future of Dermatology podcast. Remember to hit that subscribe button and share the podcast with your friends. The more you share and subscribe, the more we'll be able to grow and share our dermatology knowledge. If you have burning dermatology questions, feel free to leave them in the comment below, and we would love to address them in a future episode. And please note that this podcast is not intended to substitute for medical advice from your doctor.